I'm going to be talking about dysbiosis and gut pathogens and how we work with that. You've seen what my disclosures are. Our focus in this session is going to be twofold. During the first part of it, I'm going to be talking about diagnostic testing and being able to dive through and look at understanding the signs and symptoms and how do we apply the laboratory tools to be able to figure that out. From there, I'll be moving into talking about therapeutics, talking about how we weed, seed, and feed the gut microbiome so that it moves into balance in the best way possible, talking about different kinds of therapeutic approaches that we take. We'll have some questions in between. Liz and I will go over some things that are questions and controversies, and then we'll have a Q&A at the end of it. So I look forward to that. Sit back and enjoy. As I talked about earlier, we focus on this IBS clinical decision tree as a tool for being able to understand this dig-in approach. And within that dig-in approach, as I said earlier, we're going to look at primary causes, and those primary causes of looking at the gut microbiome relate to overall dysbiosis. What is it? Protozoal infection and pathobionts and small intestinal bacterial overgrowth, as well as post-infectious aspects. So the gut microbiota is really one of the key factors that's involved in pathophysiology of irritable bowel syndrome, but we'll also, see that it relates to inflammatory bowel disease like ulcerative colitis. We'll find that there are aspects across multiple diseases, and I've talked about this even in the pre-conference webinar and presentation to talk about the myriad ways in which the gut microbiome has an impact. Here we're going to be focusing on managing IBS and looking at prebiotics, probiotics, antibiotics, postbiotics. I'd like to start off with a case of mine, a patient of mine who's a 35-year-old woman, and she presented with chronic fatigue and immunodeficiency syndrome. When she came in, she'd had a history of anorexia and of migraine headaches, of sports when she was young with multiple concussions, traveling to India and Nepal and developing parasite infections, then really the beginning of her deeper dysfunction of her gut microbiome, although it was present previously from these other aspects. She then spent time in Sierra Leone in the Peace Corps and developed malaria twice and typhoid. When she came back, she was exposed to mold and recurrent yeast infections, was diagnosed with small intestinal bacterial overgrowth and treated. Initially felt good, but then moved into, a fatigue and brain fog kind of picture, not unlike we're seeing with some of our long COVID patients. So when she presented, we go through the multiple symptom checklist, and she had a score of 108. Less than 25 is normal, 25 to 50, mild problems, 50 to 100, moderate to severe problems, greater than 100, super issues going on. So I use the functional medicine timeline that we developed, more than 15 years ago to help us to be able to understand. And this is, the actual one that I did for this patient. I use this still in practice. It's not a concept. And so, we can see the time frame of the multiple concussions and going to boarding school and finding out lactose intolerance, but then becoming anorexic as she moved into really restricting her feeds, which are an indication to me that there was something going on in the gut microbiome previous to that. When we hear about intestinal permeability, we also find that multiple concussions, which lead to permeability of the blood-brain barrier, can also impact intestinal permeability. And then we see these infections that went on, to where she came into treatment. So as we look at the overall picture of what's happening, we see that the gut microbiome and intestinal permeability and inflammation, all three of those are important parts of what's going on for her. And so we need to dive into understanding not only the modifiable lifestyle factors, but what was really going on for her as it was relating to the information that we were going to be able to gather. And as we looked at that information, what we found was that there was an infection. She had a throat infection for which she had Pseudomonas, present in her throat. So we know that there's immune dysfunction that's going on. And when we looked at what was going on in her gut, doing a stool test, what we found, you see, there we go. What we found was that there were an imbalance in butyrate production and the overall short chain fatty acids. We also found, so we know that there's a deficiency there. We also found that there was a decrease in the beneficial bacteria that are there that were cultured out. They didn't show up in the way that we expected them to, and we found that there were many Blastocystis hominis, many parasites that were present there. Additional testing demonstrated that she had pancreatic insufficiency. A level of 64, normal is greater than 500, normal is about 700. So she is really severely pancreatic insufficiency, whether this was due to decreased signaling into the exocrine pancreas or not. But we found all of these different issues that were going on. And then when we looked at her gut IgA production, the fecal secretory IgA, we found that there was nothing there that was detectable at all. So all these things indicating immune compromise, immune deficiency, excess infection that's going on, decreased exocrine pancreatic function, alterations in the gut microbiome. Looking at additional testing like urinary organic acid testing, showed us that there were markers of not only bacterial dysbiosis, but also some of fungal dysbiosis and of malabsorption. Another test that was done at that time that we won't be talking much about today or over this course, but is looking at an adrenal stress profile that demonstrated that she was truly depleted. So adrenally, she didn't have the capacity, and that's because of the signaling from the hypothalamic pituitary axis, which we know now was secondary to alterations in the gut-brain microbiome connection, where the right signaling was not going there, as we heard Dr. Lipsky talk about a little bit this morning. So we have this lab summary of, we've got someone who's got a wound culture and infection with staph and Pseudomonas. We've got low short-chain fatty acid production, the postbiotics. We've got many Blastocystis hominis, an infection that's sitting there. We've got dysbiosis that's present, an excess of dysbiosis and immune suppression that's going on relatively. So when we look at this, we begin to say, well, what do we do with this? What's the final assessment? What's the treatment plan? How do I begin to work with this? So over the course of this talk, I'll come back to this patient several times and show you what we did and how we worked to be able to bring balance back to the system, and what we used as measures to be able to determine that there was actually improvement that was occurring, which there was, thank goodness. So as we take this case and we begin to consider, okay, how do we look at dysbiosis? How do we recognize the signs and the symptoms that are there? It's really present for a lot of people. Now, there is a webinar that I've done on the microbiome that's available in the post-course materials that will allow you to dive into this information more deeply. So think of this as kind of bathing you in a first pass of information to help you to begin to get an understanding. I'm going to go through a lot of slides and a lot of information, and I would say for you that as I began to learn this, it's just the repetition of doing it over and over again to be able to apply it with different patients that really allows you to be able to bring these tools and apply them in clinical practice, which is where our goal is ultimately. So this idea of dysbiosis, it's not a classic infection. It doesn't meet Koch's postulates. It's is not so much about the individual microbes, and we can get fixated on various disulfovibrio or Akkermansia or even various kinds of parasites. But really, it's about the milieu together of how it works, this relationship that's going on. I think about it and talk about it a lot of times with my patients as communities. What's happening with the community that's in your gut? Now, this is the most diverse ecosystem that's ever been defined, and within that, of the trillions of bacteria that are present, there's 8 billion of them on this planet, of these complex ecosystems that are working. And so when we begin to look at it, we see this disturbance of homeostasis that's going on, and imbalance. And that imbalance of the population that's there will also create an imbalance of the products, the postbiotic products, the various metabolites that are produced. It's estimated, some estimates, well, they've measured more than 1,000 different metabolites that come from the bacteria in our guts. And those are relatively consistent across all of us when we're in balance. Some researchers say there may be 10 or 20,000 different metabolites, most of which we're not even able to begin to measure at this point in time. So we can see that when someone has this imbalance, this dysbiosis, they may manifest it as symptoms of a skin problem or a gut problem or an autoimmune problem or a cognitive problem or an energy problem or a neuropathy or any of these kinds of things. So we find that the interrelationship of alterations in the gut microbiome and dysbiosis has an effect on just about every organ system that we see. Now, we can also see that there can be inflammatory responses that emerge from normal groupings of the gut microbiome. But generally, we see that there's a disruption that's occurring where there's an imbalance of who's there, that then leads to an imbalance of what is being produced that has downstream consequences to the entire body. When we think about dysbiosis, we can think about 3 different forms of it. That is, when there's a deficiency of what's supposed to be there, there can be an excess of what's not supposed to be there, and then there's overall changes in the diversity that are present. These 3 different quote unquote types of dysbiosis are not mutually exclusive. We can see times where there's a loss of diversity and there's excess, where there's a loss of diversity and there's deficiency. We can see times where there's an overall deficiency, but there are several organisms that are potential pathogens that are in excess of each other. And so we work with how do we define the ways to be able to use food and prebiotics and probiotics and postbiotics and antibiotics to be able to bring balance back to the system. We're also learning that tools like exercise and vagal stimulation can also be important, as well as relaxation response, to be able to bring balance back to the microbiome overall. And so typically we tend to think of a pathogen, like with Koch's postulate, a specific causative agent, such as a parasite, a protozoa, a bacterium, or a virus that's causing problems. But with dysbiosis, we don't necessarily see that. So I talked about the ACG guidelines for IBS, and they say, don't do stool testing for pathogens, because looking for Shigella and Salmonella these types of things are not necessarily helpful. They're not the primary causes of this imbalance. But finding imbalances in the gut microbiome itself can help us to be able to point our therapeutic tools to be able to refine and be specific in our treatments for these individuals. So when we think about the different classes of dysbiosis, we think not only of the bacteria that I've been speaking about, but we can also see the protozoa when there are imbalances in the parasites that may be present there. In countries like in in Bangladesh, or in Pakistan, we can see that having a parasite is a common thing. That is part of the normal flora in that setting. So when I say imbalances of parasites, we can see places where parasites are common and we've grown up with it and they've educated our immune system. But that's not what we see in the West primarily. So when we see a protozoa, we think it's bad, although we'll see that there are different degrees of pathogenicity that are also there. We also look at for example, the fungi or yeast. Small amounts of Candida are normal part of our gut flora, but excess amounts or other types of fungi may be an indication of an imbalance in the community that's present there. And now, so we look not only at those components, but we look at where are they? What's going on in the large intestine? Is it going on, which is where 95% of the bacteria are? Is it in the small intestine where there's going to have a specific impact on the interrelationship with what's going on with the immune system at that point in time? And we even see that there are normal flora that are present in the stomach and the esophagus, and of course in the mouth that we can learn from. So when we get into looking at, I spoke about this a little bit earlier, but there are many different factors that can have an influence on permeability. I mentioned that at the beginning of the last talk. Many of these things can be mediated through dysbiosis and alterations that are occurring here. So we have stressors and diet and inflammation and various medications and toxins that will make a difference in causing imbalances of dysbiosis, which can lead to intestinal permeability. Some of these agents, like medications, can have a direct effect on permeability in altering it, and some of it's mediated through an altered gut microbiome, leading to an infiltration of lipopolysaccharides, an increase in food reactivity that's going on and leading to systemic disease. So as we look at these kinds of things, let's talk about a systemic disease. Name a systemic disease that you would potentially associate with dysbiosis. If it's more than one word, please hyphenate it. And so we'll begin to see what are some of the diseases that are associated with this dysbiosis. So take your time to put in what you feel is something that is. We see metabolic syndrome right away, absolutely connected to that. Rheumatoid arthritis, other kinds of Crohn's disease, inflammatory bowel diseases, rosacea, migraine headaches, eczema, as has already been said, obesity, Alzheimer's disease, acne, all autoimmune disease, dementia, fibromyalgia, IBD. This is excellent. So what we're seeing is you're recognizing that, as I said, just about every single organ system in the body and most disease states that we've looked at have a correlate with alterations in the gut microbiome. One of the things I'm going to look here again. Okay, so we got depression. That's good. Depression, anxiety. We're learning so much more about the gut-brain microbiome axis. I'll talk more about that on Sunday morning. And so we can see that these symptoms of dysbiosis, which will be the kinds of bloating, of cramping, urgency, diarrhea, constipation, fatigue, bad breath, halitosis, food sensitivities, all of these are symptoms that we can find with dysbiosis. My experience is that in my practice, most patients who come in with complex chronic disease have some form of dysbiosis that's going on. So how do you begin to assess that? How do you begin to look at that? What are the laboratory tools that are really going to be able to help make a difference in that process? Now, Dr. Helen Messier, a friend and colleague for a long time, had a pre-course webinar talking about GI testing and the foundations. I'm going to go over that quickly to be able to give you a sense of, well, what are the critical factors from my perspective. So when we look at assessing gut dysbiosis, we've got a couple different tools in our toolkit. We've got stool testing that can look at classically the microscopy that's been done for 100+ years. We can look at enzyme-linked immunoassays with their antigens that will tell us about specific parasites. We can do culture methodology that's been done for 70, 80 years. We can begin to look at polymerase chain reaction using specific probes to be able to see what are the various kinds of bacteria and or parasites that are present there. Haven't talked about viruses and viromes, but that will be coming in the future to be able to understand that more deeply. We can look at metagenomics, that is using whole genome sequencing with the shotgun sequencing to be able to understand everybody who is living inside one's gut and be able to quantitate them. And then looking at the metabolites, whether that's through metabolomics, direct measures, or virtual metabolomics, where we're looking at the DNA from whole genome sequencing and being able to begin to identify, well, what's the potential of imbalances that are there. So this is where the field has really moved quite rapidly over the past 10 years, 12 years, to be able to give us a better understanding of what's going on. We also have experimentally the ability to look at urinary organic acid testing, like I showed with the patient, the 35-year-old woman with CFIDs who had some alterations in those organic acids that could tell us about malabsorption, and that could tell us about both bacterial and fungal dysbiosis that are going on. And then we also have the ability to look at small intestinal bacterial overgrowth and look at breath testing, which Dr. Asamoah is going to be talking about tomorrow. So there's multiple different ways that we can get at understanding. And we're going to start off with kind of talking about stool testing and talking about parasite detection. The ova and parasite methodology using microscopy has been tried and true for a long period of time. We're moving into an era where we now have enzyme-linked immunoassays for Giardia lamblia, for Cryptosporidium, and for Entamoeba histolytica. And those are simple tools that can be done. Each of those is present, E. histolytic in about 0.5% of cases, Cryptosporidium in a little less than that, about 0.3% of cases, Giardia, so-called beaver fever, in approximately 1% of the cases. So not very common. Now, when we've done assessments of ova and parasites where we've done microscopy, and now we're moving into an age where we've got the ability to do PCR testing with a variety of different types, a variety of different parasites as well as their subtypes. We find that there's somewhere in the order of 20% of the patients that we're seeing who have some kinds of parasites that are present there in our United States, Western world and Europe population that we've done most of the testing on thus far. Now, we look and we see Blastocystis hominis there, and that's an interesting one because, there's a consideration. Is it actually pathogenic? We know that there are 9 different strains that can be tested for with PCR testing. There's been defined in the literature 17 strains. I saw another recent paper with 23 different strains that have different degrees of pathogenicity that are present with them. So as we see here, only about 46, about half of the people who have blastocystis are actually symptomatic. Again, this suggests this differential pathogenicity that's going on. Although in that study, they were primarily looking at GI-related symptoms. But if we have blastocystis, which can cause changes in permeability, we might have extra intestinal symptoms that are going on. So it raises that question and it forces us to kind of broaden the perspective of how we think about, is it actually pathogenic? So when we look at blastocystis, for example, we find that the people who have irritable bowel syndrome are 4 times more likely to have blastocystis. We also find that when we treat those patients with IBS, the vast majority, more than 80% of them, actually get better. And when we begin to look at had other conditions such as chronic fatigue in this paper that came out, we find that after people have been exposed to Giardia, the most common frequent parasite that we see in the United States, that's commonly accepted of Giardia, Entamoeba histolytica, and Cryptosporidium, that common one, we find that 3 years after they've been exposed and treated, they have a higher incidence of both IBS and of chronic fatigue. And in those people who've been exposed, we can see this relative risk ratio of fourfold more likely to have fatigue after being exposed to Giardia than to a control population. And we know that part of that mechanism is modulated through the parasite itself actually causing changes in the tight junctions that are present in the small intestine, causing intestinal permeability and leaky gut. So now we have to consider, as we're looking at summarizing this, some pathogens, they might be commensal, and some might be associated with disease. As we look at different subtypes that are present there, we want to actually consider, do we need to treat everyone who's got this? What symptoms do they have that are going on? Certainly when we see someone who is, immunosuppressed, or may have some increased in intestinal permeability, or who may have, mast cell activation that's going on, other considerations. These are patients where we should have a higher threshold, a lower threshold, a higher likelihood of actually moving through and treating those patients. Patients who have skin problems, who have gut problems, who have neurologic problems, who have inflammatory issues that are going on. So again, we see this array of different things that we want to be considering in the process of treatment. As we move from parasites to yeast, let's go ahead and talk about, both bacteria and yeast. We need them. They're part of the normal flora. We need the products that are coming on from them. It's only when they're out of balance, when they're potentially pathogenic or truly pathogenic. And finding true pathogens is relatively uncommon in the overall picture and the approach that we're taking. So when we look at bacterial dysbiosis, as I said, standardly we've been using stool culture. When I came into this, began first working with these tools now 32 years ago, after traveling to India and Nepal and finding 6 different parasites, I began to learn a lot more about the stool culture and O&P methodology that was being able to use. But because when we're looking at stool, which is primarily telling us about what's happening in the large intestine, and the large intestine is mostly anaerobic organisms, we were only seeing about 1% of what was really happening. So we had a small little hole that we were looking through where we could see this looks imbalanced, we need to do something about it. And we would use that for treatment. But then in the 2000s and by 2010, we saw the emergence of the ability to do PCR testing with specific probes, 24 probes, 32 probes, 50 different probes, to be able to assess for some of the specific main actors that were going on, to be able to see, do we see a normal distribution, or do we see a loss of diversity that's going on there, and how do we begin to understand that and correlate that with disease? All the papers coming out in the 2000s were using these PCR probes to be able to understand the role of diversity. But they weren't telling us the whole story about what was going on. We could learn something about diversity and something about abundance. But then we've seen the emergence of the ability to be able to look at metagenomics. Metagenomics, that I'll speak to in a moment, is able to look at using these libraries of DNA to find everything that's going on. And we could also then use that to be able to determine what's happening metabolically. What is the predisposition that they have based upon the DNA from the whole genome sequencing to know what can they produce metabolically. And then there's also direct measures of metabolites, and we'll look at those, especially short-chain fatty acids that have been a great tool for helping us to understand. We've already looked at and seen, butyrates that are low, and butyrate's such an important short-chain fatty acid. So here we see examples of a couple of different, presentations of the way in which labs give us this data on bacterial culture, on yeast culture. Here's another example of it, an example of the way in which they can represent the abundance based upon PCR testing, looking at the different phyla that are there. That's going to give us a picture of what's happening in this example we see here. Looks like there's more of an excessive going on. We see excesses of many of the different phyla that are there. So when we look at 16S RNA testing, we use that where there's a 16S probe. That probe is actually connecting to the ribosomal RNA subunit, which acts as like a signature for different bacteria that are present there. And so we have species-specific signatures, and we can see how much that probe lights up to give us an idea of what's the overall abundance of that particular organism that we're looking for. But as we see, while each one of us may have 150 to 200 different species that are present, the libraries of different potential organisms are over 2,000. So if we're looking at 32 or 50 probes, we're only looking at a small subset of what's actually happening there. Now, it allowed us to be able to analyze what was going on at a relatively low cost, to be able to see a picture. And what we're doing when we look at this example of 32 probes is we're really trying to say of where is the region of a good degree of diversity, where there's neither excesses nor deficiencies that are going on. So this has been where we have focused in the recent past. Now, where we're going in the future is to be able to go from that on the left side of the 16S RNA sequencing with probes to the right-hand side, where we're looking actually at the total microbiome DNA, a whole genome approach to what's going on. This is where the cutting edge is. This is what is emerging. We're beginning to understand how to be able to apply these tools in practice, where we can really see much more about diversity. And so we find that metagenomically, that's telling us like the composition of who's there. I call it like census taking. You're finding out who's actually there. And then we look at what's going on metabolically. What's the metabolic activity, the product, those 1,000+ metabolites that are being produced by the microbiome at that point in time. We recognize that structure and function are not the same thing. And so when we have people, it doesn't matter. I like to use the terminology with patients that diversity that we may see in the composition, in the metagenomic composition, diversity in Seattle, where I'm talking to you from, is different than diversity in Hong Kong, which is different than diversity in Istanbul. So we can have multiple different organisms there that are producing the same metabolites. So we really want to focus on, and in my practice, I really focus on what's going on metabolically. The composition is giving us an idea of where imbalance is, but the way it's playing out is what I really care about. And here's an example of a metagenomic picture, that looks at the phyla, the genus, the families, the genus, the species, and the strains that are there. This is me, so I'm happy to report it. And we can see that there, when we begin to understand this kind of sunburst picture, there are forms of imbalance that are occurring there. So now I want to move away from talking about bacterial dysbiosis and measuring that to talk about yeast dysbiosis. And Dr. Lipsky mentioned Dr. Bill Crook earlier, who talked about yeast overgrowth and yeast dysbiosis and leading to a number of different symptoms that are going on, as we see over on the left. Now, Candida albicans, as I noted earlier, is a part of the normal flora of the gut. It's present there in low levels. When it's present there in high levels, we can begin to see issues that occur. It lowers mucosal immunity and leads to an impaired host immune response. We also see that when there's increases in Candida, there are increases in inflammation that goes on. And so elevated Candida levels in the gut, which we can measure through colonization or culture methodologies, as well as some PCR technologies, it's associated with a number of different diseases, specifically within the gut. But as we saw, imbalances have also been associated with mitochondrial defects and dysfunctions, such as brain fog and chronic fatigue and things of that nature. So, what do we do? There can be a vicious cycle if there's inflammation and there's permeability issues that are going on, and it can lead to greater amounts of Candida. And there's some great papers, this paper on yeast in the gut, talking about specific ways. Again, normally we would find about 100 to 10,000 colony-forming units of Candida would be normal in a gram of stools. But so we wouldn't be treating that. But when we see excesses of that, we really want to consider treating that. And as we'll talk about later, the ways in which we treat it are first, pulling away the sugars and the sugar alcohols and the things that are going to be feeding the yeast, and then determining, do I actually need to use an herbal antifungal or a supplement or a pharmaceutical antifungal. We'll talk about that as we go on. Other things that we measure in the gut include these short-chain fatty acids. And I've mentioned, so the starch and the non-starch polysaccharides are connected with the bacterial enzymes, and they make these short-chain fatty acids. And these are used primarily as fuel for the colon. Butyrate itself acts as an agent that is the principal fuel source for the colonocytes in the large intestine. But they have broader effects that are anti-inflammatory and immunomodulatory in nature. And the different short-chain fatty acids, whether it's butyrate or propionate or acetate, have different effects that go on that we want to look at. These are the three primary short-chain fatty acids, but there are a number. We heard earlier about the products of protein breakdown, that when we have insufficient hydrochloric acid, we have insufficient breakdown of proteins. Those proteins go down into the terminal ileum and can get modified into putrefactive short-chain fatty acids of valerate, isovalerate, and isobutyrate. So there's, again, different ways in which this data is represented through the laboratories that are doing testing on it, but it gives us an idea of the metabolites. So we're looking at culture, we're looking at a microscopy, we're looking at what's happening with PCR. We're looking at what's happening with whole genome sequencing. We're looking at what's happening with the metabolites that are going on there. So you can see, as I've moved through this, and we've covered each of those different areas. Now, moving on to the experimental analysis of organic acids, we can begin to see that there are markers of dysbiosis, the DHPPA, which is associated with an excess of Clostridial species that are going on, the 4-hydroxyphenylacetic acid and benzoic acid that have been described for a long period of time in terms of imbalances that tell us that there are bacterial populations and what they're producing, again, the metabolites, are out of balance. The same can be true as seen with yeast, where particularly the marker of D-arabinitol has clearly been associated with a fungal overgrowth picture that's going on. It's normal in this phase, and some of those agents like tartaric acid and citramalic acid can be affected by the diet, but it's the D-arabinitol that is going to be the most important of those considerations. So as we go through and we're talking about, the gut microbiome and looking at what's the picture of more deeply understanding, and we look at those aspects of the modifiable lifestyle factors and what to do, let's go back to this case study of the 35-year-old who was there. So what we found was I showed you the laboratory summary, some of which may not have made sense to you when I first presented it, but low butyrate concentrations, lots of blastocystis hominis, low fecal secretory IgA, that we'll hear more about later. Then elevated malabsorption markers, elevated organic acid markers. When we begin to see this, what is the assessment? So I want you each to think about, okay, so what would I do for this individual at this point in time? Even take a pen and write it down. Just go back there for a moment and say, okay, so we know she's got blastocystis hominis, you're going to treat that. Pancreatic elastase, you're going to treat that. Immune dysfunction, you're going to treat that. Dysbiosis, you're going to treat that. How do you begin to think about putting this together? And in the latter half of the talk this afternoon, we'll be focusing on, well, what are the actual treatments that we would choose to use? But where do you go? How do you create a prioritization for this individual? One of the other areas that I wanted to talk about briefly is I wanted to talk about H. pylori. We know that H. pylori is actually it's a normal flora in the gut of indigenous people that go on. So I worked with the Yupik Eskimo people for a couple of years, and we found that 75% of the patients had H. pylori that was present. We would treat them with triple antibiotic therapy, and it would come back right away. So is it actually pathogenic? And what we find is that there are some subsets, some subtypes and strains of H. pylori that clearly are associated with gastric cancer. But we know that even though the rates of H. pylori are high, the rates of gastric cancer range pretty broadly across different areas. And so what the question here, since we're talking about diagnostics, is, well, do we need to test for it, and what's the best way to test for it? So over time, the urea breath test has been the gold standard, but we have moved towards the use of tests of stool tests that look for the H. pylori antigen that are equally effective or just about as effective as the breath test. Doing antibody tests, not very helpful because it doesn't tell you whether it's active or it's in the past. Now, there's PCR testing that has been done, and this is where some of the questions come in, because the PCR testing is one where if there are low levels of H. pylori, it does not necessarily mean that it's pathogenic and should be treated in this way. And so it raises a question, are people being inappropriately treated for H. pylori for which they actually don't have pathogenic amounts of it at this point in time? Now, H. pylori can have lots of different clinical consequences and manifestations, and the treatment guidelines, as you're probably familiar with, are using, triple therapy and quadruple therapy. Then there's also adjunctive therapies that we recommend in the case of doing that, rather than using a large bazooka of antimicrobials or antibiotics that will clearly disrupt the gut microbiome. Rather, we can use things like NAC and mastic gum, oil of oregano, ginseng, garlic, green tea, and even Saccharomyces boulardii has been shown in a recent trial. So we want you to consider, well, who are you going to treat? You're going to treat them if they're symptomatic or asymptomatic. Is this part of the normal commensal flora? Can we evaluate the specific strains that are KA positive, which have a greater ability to be able to drive and create punctured holes in the gut that's associated with increases in gastric cancer? And then we also find, do I want to deal with the antibiotic resistance that may emerge from the triple and quadruple therapies that we're using? So it's pretty controversial from my perspective, although I've had teachers who say, this is a no-brainer. Everybody should be treated all the time. I take a more cautious approach on the whole thing. So I want to invite Dr. BOHAM in here, Liz. Let's have a 3 or 4 minute conversation about what kinds of questions come up for you as you hear me talking about this.
Well, Patrick, great job, and I really would like us to talk a little more about this H. pylori question, because I find that I have a lot of patients who come to see me who have maybe had a stool test by another practitioner, and there was a PCR positive for H. pylori, and they've either been treated or they've been recommended treatment for the H. pylori. And so I wanted to just get your sense of that. If you have somebody who comes in to see you and they present you with a positive PCR to H. pylori, what do you do?
Say, this isn't helpful, but it raises a question. So let's go ahead and get a stool antigen test of H. pylori to see if you actually have it in a sufficient amount that would require treatment. Then, and I'm different than many practitioners, then I look at, well, and what's going on with you at this point in time? Are there symptoms? Has there been ulceration? Has there been bleeding? Is there dyspepsia? Interestingly, we see that when dyspepsia goes up, H. pylori goes down. And when H. pylori goes down, dyspepsia goes up. So if they have a lot of dyspepsia, that's actually an indication that maybe I don't need to treat this. Maybe that will get worse if I do it that way. And so I bring in other agents to consider. And in the meantime, I may use like a mastic gum or something like that to be able to see, does this help any symptoms that you're having right at this point in time? But I want a positive test, either a urea breath test. Don't do that very much anymore, but the stool antigen test is clearly gold standard.
Right. So you want a positive stool antigen test before you're going to treat or think about treating.
Absolutely. Before I'm even going to think about it.
And what about of course that's the triple antibiotic treatment, right? But even what about herbal treatment? Do you feel the same way about using like an herbal combination in that situation?
Well, you can do that, but my experience is that in terms of eradication of H. pylori, when looking at the stool antigen, they're not that effective. Right. It's unfortunate, but some of the agents, as I'll talk later about parasites, like when I'm treating parasites, I need to use a pharmaceutical agent along with an herbal agent. I have not found in my experience that herbal agents alone are sufficient. So if I'm really concerned about H. pylori, I'm going to use those as adjuncts to be able to support the other kinds of triple therapy.
And I've wondered if we're going to be getting 40% or so of, if we're doing PCR testing and including H. pylori, if we're going to be seeing 40% of people coming back positive on that, right? Are we going to see a large percentage?
Yeah, I don't know.
See a large percentage, right?
Yeah, I don't know what those percentages are, but right. The data that's been done will show that at least 50% of the people who are having a PCR positive, that the data out of Baylor, do not have a positive antigen test.
Right.
So, it's there, and it's something to consider, but don't, treat the person, not the lab.
Yeah. Thank you.
You bet. Thank you. So, as we go on into this portion where, kind of briefly talked about diagnostic testing, and, I moved through that pretty quickly. Again, you can go back to listen to this and to the webinar from Dr. Helen Messier that talks a bit deeper about the specific testing that can be done. But it does help to guide us, and it helps us to then be able to determine, well, where is the dysbiosis that's going on, whether in bacteria, yeast, or parasites. And that's the next part that we're going to go to is well, how do we compose treatments for that? And the way in which we approach this is talking about weeding, seeding, and feeding. We're working to rebalance the gut. We're working to get rid of that which we don't need, just like we learned on the very first day of our AFMCP, that is to get rid of that which there is too much, and add more, replace more, remove and replace. Those are the first two parts of the quote-unquote 5R treatment sort of approach. So weeding and seeding, I'll talk about that here for a while, and then talking about feeding of how do we do that. So our focus is to bring balance back to the gut overall. That's really what we're trying to do. We're not trying to eradicate a specific organism. We're not trying to promote the increase of a specific organism that's going on. What we find is that different tools that can be used to be able to help bring balance. We can use those things that are going to eliminate potential pathogens or problematic foods. We're going to use the elimination diet. We're going to remove. We're going to consider probiotics. I like to use the term bugs as drugs, because what we're going to find with probiotics is the non-specific administration of them, just as we heard from the ACG IBS clinical practice guidelines, the non-specific use of probiotics to broadly to be able to help is not been demonstrated to be helpful. But the specific use of specific strains and doses of probiotics for specific periods of time for specific diseases has been shown to be quite beneficial. And so we'll talk about that data a little bit, but overall, in this setting, what I want you to recognize is that saying, oh, I'm going to give you probiotics is like saying, I'm going to give you antibiotics. And we don't just write on a piece of a prescription form or in our ERX, we don't just say antibiotics, 1 a day for a month, take every morning with food. Saying that with probiotics is equally problematic to be able to do. So specific probiotics for specific diseases and specific people at specific times. And then we also have the ability, as we heard Dr. Lipsky talking about, of food as medicine. And we take a food first approach. If we can work to bring whole foods and diverse plants and a diversity of phytonutrients and polyphenols and flavonoids to be able to feed the bacteria so that they produce a diverse array and a balanced array of metabolites and postbiotics, that's really what we're going for. So we have different kinds of ways to be able to bring balance to the overall diet and to help to bring balance back to the gut microbiome. So we're going to talk about all those things. But first I'm going to talk about looking at treatment from a Western medical perspective, and that again, when we're treating dysbiosis, we're not treating something that meets Koch's postulates as a pathogen. We're actually working to bring balance back to the system overall. The antimicrobial therapies, and we'll talk about some of those. We look at rifaximin for SIBO, and we look at various kinds of nitazoxanide and other agents for parasites. There are times where that is necessary to do, and we will highlight those. But really bringing balance back to the system is key. So when we're weeding, we have to consider, well, how do we bring balance back to the gut flora? And are there some things that we want to do with diets, such as a low FODMAP diet that will decrease the FODMAP stands for fructooligosaccharides, disaccharides, monosaccharides, and polyols, but there are specific agents that will feed bacteria that can cause bloating, that can cause overgrowth that occurs. And as we go into defining each of these agents, of looking at elimination of problem foods and being more aggressive in our approach versus probiotics versus diet, where we're going to be feeding the beneficial bacteria and helping them to grow. We first want to make it hard for the weeds to be able to grow. In the setting of looking at, we'll talk about a continuum here of moving from normal to excess. And when we have excesses of parasites, when we have excesses of potential pathogens, that's when we're going to, choose to use various antibiotics or botanical antimicrobials. And it's important for me to note that when I'm looking at botanical antimicrobials, I'm thinking of them in a similar way as I would be with an antibiotic. I didn't used to in my career, and would be using golden seal and other kinds of extracts to be able to treat ear infections, thinking, well, it's not an antibiotic, so it's fine. But we can find, as we see in this pictorial representation here, we look at the bacterial cell count on the y-axis, and we see the different kinds, the different colors, and the diversity that's present there. And then when the antibiotic treatment comes, we begin to see a loss of that diversity, and we begin to see specific kinds of bacteria that are able to grow, and many other microbiota that are not able to grow at that point in time. And what I want to point out here is that on that point on the x-axis, where it says antibiotic treatment and end of antibiotic treatment, if that said antimicrobial treatment, herbal antimicrobial treatment, and end of herbal antimicrobial treatment, it would have a similar picture to what goes on before the diversity is able to reemerge after the end of that. And so we find that, antibiotics in this in this picture, does show that, over time at day 7, 21, 3 months, 6 months, 9 months, even 24 months out, we do not see a full reversal of the diversity that was present before we gave in this case, the clindamycin in the first place. So studies show us that when we give antibiotics to kids over and over again, that it actually increases the rates of obesity that go on. In this particular study that was done, we found that there was a 2-fold increase in the development of obesity in kids when they were exposed to recurrent and broad-spectrum antibiotics for common childhood infections that are going on. So we know we have to be careful about this because it will cause disruptions, and this is sort of the warning signal about what's going on. So we don't want to be overly aggressive as we're working to pull the weeds. If there are true pathogens, such as we see with Clostridium difficile, they may need something, but as we'll find later, the best treatment for Clostridium difficile actually is a fecal transplant. And so we're learning to be able to adjust and not be overly aggressive in what we do with the gut. And when we look at other agents, other things that we need to weed, parasites or yeast that's going on, we begin to find that there are many, many different kinds of fungi that are present in our gut. And in this list of 36 studies, they found at least 267 different kinds of species that are there. And we want to have a diversity, but most of the bacteria that are present in our gut are going to be Candida and Saccharomyces. Those are the common ones that are there. And we're going to look to see, are they present? Are they present in low amounts, or are they present in high amounts where there's an overgrowth that's occurring? This picture is helping to remind me that there's the commensal bacteria or commensal fungi, such as Candida, and then there are environmental fungi that we get exposed to through breathing and through foods that we have. Both of them can be imbalanced, and it's only when we have an abnormal interaction with them or excess amounts of them that they lead to increases in disease. And treating the environmental fungi of the Aspergillus is different than treating the commensal fungi like Candida that are overgrown. I alluded to this earlier, but the first thing that we're going to do when we're working to treat intestinal yeast like an overgrowth of Candida is we're going to eliminate all the sugars, refined grains, white flour. We're going to have people eat a diet that's higher in protein, lower in carbohydrates. Could even go to a ketogenic kind of diet, something that's high in fiber. We're also going to avoid fermented foods. We're going to avoid alcohol. We're going to avoid the kimchis and kombuchas and other agents that are out there that will actually tend to feed the intestinal yeast as it moves forward. So the anti-Candida food plan is something that Dr. Lipsky will speak more about tomorrow. Now, as we go forward and we talk about other kinds of agents, the agent that I like best is Saccharomyces boulardii. Saccharomyces boulardii is a yeast. It's Saccharomyces cerevisiae subspecies boulardii, developed in France in the late 1800s. It's been used for GI illnesses for a long period of time and actually can help to prevent, if you're going to use an antibiotic, I often give Saccharomyces at the same time because it prevents that fungal overgrowth from occurring at the same time. Other kinds of probiotics and enzymatic therapies, the enzymatic therapies of the DPP4, the peptidase, and the amylase are particularly helpful if there's a biofilm formation that has gone on or there's a suspicion of a biofilm layer that's occurring. Specific antimicrobials or botanicals, oregano and oregano oil at 200 milligrams 3 times a day, particularly helpful for its antifungal properties. The two I like here are the aromatics, oregano and thyme. We do see garlic and golden seal and other combinations that are present there that can be useful, but it's the aromatic oils that I find to be most helpful in their anti-yeast capacity. And then sometimes there are pharmaceutical options that are necessary. In my practice, the one that I use most is fluconazole. I found it to be very effective. I was very worried about it early on in my career that it was going to cause liver function problems, which is what we're told. I've only ever seen it once in my practice, and that was someone who had chronic hepatitis C and didn't tell me. So I'm convinced that it's a fairly safe drug to be able to use. Nystatin, which is a drug that was actually developed in New York State by their lab, and that's why it's called New York Statin. Nystatin is a non-absorbable antifungal. Can be useful in a variety of settings. I haven't found it to be as effective. Other agents like itraconazole I find to be useful more for the environmental exposures of molds and mycotoxins that are present than in versus the intestinal or commensal fungi like Candida. Now, taking a similar approach of saying, well, where do I go with parasites? My experience has been that with parasites, I need to use both herbal or botanical anti-parasitic agents along with pharmaceutical anti-parasitic agents. I use them together. The two that I use most are the nitazoxazide and the tinidazole. Metronidazole, common, but there's an increased risk of resistance by many of the parasites that are present. So you can see in our forms here of which specific parasites and which is the most common treatment. The bottom one, I find that about 12% of the patients who I do testing on for parasites will have blastocystis hominis. Now, whether or not it's a pathogenic strain is a question. It depends upon what kinds of symptoms they have. If they have gut or extraintestinal symptoms that may indicate intestinal permeability, I'm going to treat it. And when I treat it with nitazoxazide at 500 milligrams twice a day for a 10 days period of time. So I usually combine that, again, with an oregano oil in a capsulated form of 200 milligrams 3 times a day for 10 days. I've found the Artemisia and Chinese wormwood also to be a useful thing to add instead. If I'm not using oregano oil, I'll use that, and I'll use those agents for a 4 to 6 week period of time. There are other combination products that include black walnut and Artemisia, garlic, and olive leaf that are helpful. Citrus seed extract I find to be more useful as a preventive agent, small amounts of that when I have people who are traveling internationally who are concerned about parasites. I think about that. Let's see where we're at. So, going through, if you will, the weeding process. This is a summary slide that says, if I'm seeing some pathogenic bacteria, then I'm going to be looking at antimicrobial therapies and sensitivities. We see that the testing labs that are looking at those potential pathogens will also tell us not only about the pharmaceutical antibiotics, but also the antimicrobials that are commonly used and what the degree of sensitivity or resistance is that's going on there, if we need to be able to do that. When we're looking at yeast, at removing yeast, the idea of first using dietary approaches to be able to simplify, to stop feeding the yeast and seeing if those problems continue on. If they do, then moving into a consideration of an antifungal pharmaceutical product or an antifungal botanical product. Either one, I found both work pretty equally well. And versus parasites, where I find that I need to use the anti-parasitic pharmaceutical agent specifically in addition to the botanical anti-parasitic aspect. And that treatment is usually for a 10-day period of time, unless I'm using something like Artemisia or wormwood to be able to use that for a 4 to 6 week period of time. So that's weeding. Now we're going to move into seeding. And in seeding, I have to say that I don't particularly like this particular terminology. What we're doing here is we're seeing when there's an imbalance, and we're seeing how do we bring the right balance of microbiome to be able to be there? How do we see that? Now, it was thought by me and others early on that with probiotics, that if you gave probiotics, you would actually be working to seed or cause change or inoculate, like grass seed, to be going on. And we found that's not actually the case, that probiotics act as tourists. They move through the system and they work to have an impact. I live in Asheville, North Carolina. Over the almost 30 years that I've lived there, I've seen many more tourists come. It's changed the way my town moves and exists. So having the right amount of tourists to help the economy of your gut is a good thing, but having too many tourists can actually cause some disruption or dependency that goes on. And so we'll find, in talking about probiotics, which this next section is going to focus on, these are organisms that are of a human origin, that they're resistant to destruction, that when they pass through the upper GI tract and the gastric acid and the bile, they don't get disrupted, and they're able to help to, the word here says colonize, but they're not actually colonizing. They're present there. The data shows us that probiotics act for up to about 13 days period of time. Now, they have a metabolic effect and they cause changes that are happening. And so there are changes in the overall structure or census of what's going on in the gut microbiome during that period of time. But one of the reasons why they've been used so broadly is because they have a very, very low toxicity associated with them. And so there have been studies that have done that says that, we can actually, it seems like there's an improvement in the overall health status when we're using probiotics. Decreased number of days of work lost, and even though we've had many fewer antibiotic prescriptions that have happened, we actually see the disease outcomes are doing well. So probiotics will have an effect. It can have an effect on the immune system. That's the first big thing that we know about. But probiotics can also regulate motility. They can support the mucosal barrier. The mucosal barrier, which is about 30 microns thick, is actually, or 30 micrometers thick, is made up of mucopolysaccharides, but also various bacteria that are present there. And if we have dysfunctional or pathogenic, potentially pathogenic bacteria, we don't want them there. The probiotics can intercalate into that and help to make a more beneficial mucosal barrier support. But it's temporary. It's there while you're taking the probiotic. It appears to be able to help regulation overall and prevent some kinds of infections. So we see metabolically the probiotics have a very beneficial effect. And when we look at this forest plot of looking at different kinds of diseases and different probiotic species, we find that by and large, the probiotics are going to be effective. They're, with the 95% inner confidence intervals that we see that it's helpful for antibiotic-associated diarrhea, for C. difficile, for H. pylori, for IBS, for infectious diarrhea, for necrotizing enterocolitis, a lot of different issues. We also see that there are probiotics that have been demonstrated to be useful combination strains for things like ulcerative colitis, both in terms of inducing remission and maintaining remission. Dr. Beaulieu and Dawn will be talking about some of that tomorrow, but that's specific to ulcerative colitis. So, we find that the probiotics in specific focal points are useful. One of the big new areas of interest right now is in the term that is called psychobiotics, that are probiotics that will have an effect on the psychological system, on the central nervous system. And we can see that when there are or certain bacteria that are present in the gut, they can have an effect on changing the production of immune cytokines, on changing the production of serotonin and other neurochemical activators, changing the signaling of the vagus nerve, the efferent signaling that's going back to the brain. We see that the production of short-chain fatty acids and 5-HTP and other things will have an impact on the brain itself. Again, talk more about this on Sunday morning, but the data starts to tell us that when we start to look at probiotics on depression, there are certain specific probiotics that will have an impact on decreasing depression, on decreasing anxiety. We can also see, as these studies show, that we can see an impact on autism spectrum disorder, that we can see an impact on overall cognition, that we can see an impact on attention deficit hyperactivity disorder. We can see a process on the improving cognition overall. So when we look at these studies, we say, okay, there is something here, but we have to be able to target our probiotics. So in looking at this meta-analysis, we can see this forest plot is looking at, is there a difference in dose? And when they used less than 1 trillion colony-forming units, or 100 million colony-forming units, or more than that, do we see a difference that goes on? Not really in the IBS subgroup. How about if the duration of treatment is less than 8 weeks or more than 8 weeks? As we go down through that, we see that most of those measures actually are touching the 0 line or the 1 line, that's indicating that there's not a true benefit that's going on. And there are a few agents that are specifically helpful for that. Are these strain-specific effects that we need to consider when we look at something like Bifidobacter infantis? There are many kinds of Bifidobacter infantis, but the strain called Bifidobacter infantis 35624 has specifically been shown to be useful, for a 30-day period of time. So even some of this is strain or subgroup specific that we need to look at. Now, overall, when you're looking at the data, you're saying, well, gosh, it doesn't look like it's that big. There's a lot of overlap or a lot of touching that line 1, and that's why we see the ACG guidelines don't say yes, use probiotics. It's some strains at some dosage patterns and some time frames can be effective for IBS. But this comes to the big question. So, well, which organism do I use, and for which product, and for how long, and does it need to be refrigerated, and what happens if it's not, and what are the side effects, and how much does it cost? So the common probiotic supplements are going to have lactobacillus and bifidobacter that are in them. That is, the definition of what a probiotic is. It includes Streptococcus species, Strep thermophilus, and it includes Saccharomyces boulardii that I mentioned earlier, which is a subtype of brewer's yeast. So when we look at these, we begin to say, well, how do we determine what's the best thing to do? So what I tell my patients and what I tell doctors and clinicians like yourself that I'm teaching is you have to look at the quality control of what's going on. Because when the studies have been done, the probiotic, the supplement industry, not well regulated. And so we can see that there are, practical issues that occur. Anyone can put out a probiotic, put a label on it and say it's probiotic. But when they actually start looking at them, like these studies in the UK and in the US, what we find is that, in the UK study, 43% of the products didn't have what they said they had in them. And when they said they had multiple strains, none of them had all the strains that they said they would have. And so even when we have the labeling that occurs in the United States, again, a third of the probiotics don't have what they say they have in them. So there's truly a quality issue that goes on. And there's also practical issues where we can have agents that may cost as much as $100 a month month, and agents that may be $15 a month to be able to use. Generally, when we're using probiotic therapy, we're going to use it for a 3 to 6 month period of time. If I'm using long-term probiotics, I'm going to switch the probiotic after a 6 month period of time, so it's not the exact same one that's going on. I want to be able to create some diversity. But in my practice, while I've used high amounts of many different kinds of probiotics over 30 years, really my focus now is on how do I get probiotic and commensal flora-rich foods. So when we take something like a yogurt or a kefir will have many other kinds of organisms in them, not just the classic probiotics that we see in a capsule form. We can see fermented foods, kombucha, fermented vegetables, kimchi and sauerkraut, pickles. All of these foods are going to help to promote and going to have beneficial bacteria present in them. We see this in cultures around the world over eons, or millennia at least. And so when we're looking at that, that's where my focus is with patients. Let's talk about one difficult area of treatment, and that's Clostridium difficile. So Clostridium difficile, we know as an infection can cause pseudomembranous colitis, and the patients can become super sick. One of the forms that I would use early on with C. difficile were high amounts of this Saccharomyces boulardii. Now it's starting just at 250 milligrams twice a day, but doses that ranged up to 1 gram twice a day, for patients who were even hospitalized, because the Saccharomyces boulardii, helps to improve the production of the secretory IgA. It actually inactivates some of the toxins and decreases the inflammatory tumor necrosis factor alpha. It also works to be able to help modulate and stimulate the brush border enzymes that are present there in the small intestine. So we see that there are interesting kinds of approaches that we can take to be able to treat with C. difficile, Saccharomyces boulardii being one, as I talked about with its brush border activity. But there's actually another treatment for Clostridium difficile that includes fecal transplants. That is the only FDA-approved indication for fecal transplant at this point in time. I'll talk more about that in a moment. So when we're looking at which probiotic are we going to prescribe, and how do we do that, we look to, well, what are different resources that are available? I particularly like Dr. Jason Hawrylak in Tasmania, who has something called the Probiotic Advisor. It's a subscription, but it's an excellent source for being able to have good data that's unbiased in any way, shape, or form. We see the USProbioticGuide.com and the Natural Medicine Database, both of which will give us good information about the probiotics. Mentioned briefly about safety and efficacy. Generally, probiotics are considered very, very safe. We've seen billions of capsules being given, tens of billions of capsules over the past 20 years. And we've only seen a few rare episodes, less than 1 case per million people who are taking these, of having some kind of translocation that occurs. Some of that translocation has occurred in patients who are really sick, like patients with pancreatic cancer, stage 4 pancreatic cancer, or severe acute pancreatitis. So there's also been several reports of fungemia from the use of Saccharomyces boulardii. Again, this is going to happen in cases where there is significant increase in intestinal permeability and leakiness that's going to allow these organisms to move in and to be able to circulate systemically. And again, a couple of other reports. But on the horizon, many people have talked about fecal transplants, and I've alluded to it several times. One of my colleagues and I, Dr. Tom Soldna, were considering this about 15 years ago as we began to see the emergence of it. But there are some interesting studies, and there are some interesting issues, that arise from that. So when we look at, the randomized controlled trials looking at irritable bowel syndrome actually showed that they had some decrease in symptomaticity that went on, 56% in the donor pool versus 26% in the placebo group. But they weren't effective at being able to change overall the Rome criteria for these individuals. So they got some symptomatic relief that went on. And, we see when we look at the data for Clostridium difficile, where it's absolutely unequivocal of the improvement that we see, of improvements in patients with C. diff, where it's an 86 to 93% improvement, whether it's given endoscopically or whether it's given as an enema. We also see some interesting data in ulcerative colitis, although not yet up to meeting an FDA standard for using that. And we see with ulcerative colitis, I think about that as an area where there's specific issues with the gut microbiome that need to be addressed in order to help bring balance back to the system, unlike Crohn's disease, as we'll hear Dawn talk about tomorrow. But when we look at updates on fecal transplants and studies that have been done looking at obesity and metabolic syndrome, studies that have been looking at cirrhosis and non-alcoholic steatohepatitis and primary sclerosing cholangitis and even hepatitis B, some fascinating data that's there. And as I said, when we look at the data with C. diff, 90% clinical resolution, not a significant amount of adverse effects. And when we look at the published literature across a number of different disease states, we see that there's a lot of studies, there's a lot of interest in this at this point in time. But I want to give a caveat about this, and that is, if a fecal transplant, if our gut microbiome can have an impact on every single system and many different kinds of diseases. If we take someone who's got irritable bowel syndrome or eczema and we give them a fecal transplant, but unbeknown to us, we're giving them a fecal transplant of someone who's actually got the fecal composition and metabolite composition that is going to lead towards cognitive disorder or cardiovascular disease or Alzheimer's disease, and we don't know. Do we want to do that? So the fecal transplant issue is not one there's an easy answer to it. There are companies that are working on postbiotic metabolites. There are companies that are working on creating poop pills that will become available. But there was a promise of this is going to be the next phase of pharmaceuticals, and we're not actually seeing that in practice, and there is some risk associated with it. So while I'm a big fan, I'm also very, very cautious. So when we look at the idea of seeding, the first steps that we're going to do are focus on foods. If we're going to treat, we make sure we have a high quality product, and in that high quality product, we're going to use it for initial 6 to 12 weeks. If we use it for more than 6 months period of time, we're going to switch to a different probiotic, but we're going to try to come back to food to help that make the biggest difference. So, Liz.
Well, thank you, Patrick. Oh my goodness, what a great subject area, and you really tackled it with the probiotics in question. But I guess I know you've really talked through this a lot, but how do you practically choose a probiotic? And do you find that it's a little bit of a trial and error thing, or how do do you have just some of your favorites that you use, or how do you choose one for a specific patient?
Well, it's for a specific patient and for a specific disease. So recently, I've been reading about psychobiotics and looking at the literature and saying, okay, well, these are the specific things that are helpful for anxiety, and they're different than the ones that are helpful for depression. And then where can I find that one? And the companies that say, here's our probiotic for depression, and I look at what's in it, and it's not what's in the literature. Like, where can I find that strain at that dosage to be able to do that. I often find them in unusual places, where they're not actually promoted for that indication, but they're present there in a probiotic. So I work with online dispensaries, and I have a couple of other companies I have direct relationships with where I'm purchasing probiotics, but I'm really trying to dial it in specifically. What's the dose? What's the strain? Not just the type of bacteria, but the strain of bacteria, right? Like, so you heard me talk about Bifido infantis. Yeah. It's a very specific strain. And when you read the literature on psychobiotics, there are very specific strains that they're looking at. Plus, I don't care if it helped with anxiety in a mouse, right? Mm-hmm. It's got to be human studies in order to do that. And how can I find that? And how can I dial that in? And so I am quite specific in what I do for each different disease state that's going on.
That was really helpful. Thank you.
You bet.
I'll be back.
Okay. Where are we here? Well, maybe just a deep breath, stand up, stretch, allow yourself to be able to feel into what's going on. I've got a timer here, and I'm having to change in my head from hours and minutes to just minutes to figure out where I'm at. So we're a little bit behind, but we'll continue on. We've got about 20 minutes more, and then we'll be moving into a Q&A. And so I've talked about weeding and seeding, and now I want to come into feeding. And this is that aspect that really gets down to the food first approach that we're taking. Dr. Lipsky did the pre-course webinar on the diet prescription. You hear us talking about different foods all the time. As we move along this continuum of looking at imbalance that's occurring, we want to take it into that aspect that's talking about fermented foods and soluble fiber and prebiotics and food as medicine. Now, when we started talking, even at the beginning of this course in 2009 that Dan's talked about, we thought that the gut microbiome was pretty much unchangeable from the time that you were about 4 years old. But what we've learned is that the gut microbiome is changeable. It doesn't change if you keep eating the same diet. But if you shift your diet, and we found, Peter Turnbull and Jeff Gordon at Washington University, found that they could actually shift from changing from a plant-based diet to a high sugar diet. They could change the gut microbiome in a day. Other studies have been done by Dr. Oz et al., demonstrating the same kind of thing. Here we see the population on the left, which is mostly green with the Bacteroidetes. That's a patient population from Burkina Faso eating traditional foods. On the right, we see a population from Italy eating mostly Western foods and pasta. Maybe it's a modified Mediterranean diet, but it's not actually great for the gut microbiome in this case. So when we look at how do we modify the gut microbiome, we find that diet is the principal source. Now, there's more emerging data that says that exercise can make a difference, that mental health status and meditation and dealing with stress can make a difference, that sleep can actually make a difference in your microbiome, so those modifiable lifestyle factors. But the diet for restoring the gut microbiome is the key thing. And as we get into it, again, not unlike the ACG guidelines that I talked about in the last session, soluble fiber, looking at modified citrus pectin, partially hydrogenated guar gum, acacia root, as well as many other forms of soluble fibers. These are key factors. Paleolithic man and woman, ate more than 100 grams of fiber per day. In our culture, we consider a diet of 35 grams of fiber to be super high. Saw a note from Dr. Perlmutter talking about the carnivore diet. Now, if you have the carnivore diet, you're not getting the fiber that you need. I think Liz talked about this early today. So how do we help restore the inner ecology through fiber, through fermented foods, through decreasing simple sugars that we're having, to decreasing refined carbohydrates in our diet? These are going to be the things that are going to make the biggest difference. We heard Dr. Lipsky talk about the specific carbohydrate diet before. We've talked about the low FODMAP diet, and we'll hear a little bit more about that tomorrow. But those are diets that are just working to decrease specific agents that someone might have some reactivity to. But ultimately, what we want to do is we want to let food be our medicine, and that the prebiotics, and whether they're Jerusalem artichokes or ginger or scallions or asparagus or onions, all of these are specific foods that are going to be helpful to produce, that are acting as prebiotics. So prebiotics help the beneficial bacteria to be able to grow. Not only the bifidobacter and lactobacillus, but they're going to produce the short-chain fatty acids. And when I talk about this, I talk about it like we use short-chain fatty acids just as the proxy. When we talk about butyrate, butyrate's the answer. Butyrate's one of 1,000 molecules that are there. It's an important one. It may be the most important one, but if there's 1,000 molecules, you've got to actually work to bring the whole milieu back into balance. And that's what we're working to do. And they'll have beneficial effects on the pH of the gut, on the overall health and well-being. Because we know that when we have a sick gut, it doesn't have those nutritional components in it. There's going to be increased inflammation and activation of nuclear factor kappa B and TNF alpha. There's going to be bacterial translocation that can happen because there's intestinal permeability that goes on. We see that imbalances between the Bacteroidetes and Firmicutes, they move more towards the Firmicutes, which is an imbalanced state and tends to be more pro-inflammatory nature. We tend to see an increase in insulin resistance or a decrease in insulin sensitivity. It's my premise from dealing with this for a long period of time that a lot of what we see with insulin resistance is mediated through the gut microbiome, and the gut microbiome leads to having changes that will affect insulin sensitivity patterns that go on and low-grade inflammation that we're not able to assess with something like a SED rate or a CRP. We're beginning to understand what's the constellation of bacteria, and of course, what's the constellation of metabolites that is telling us that there's more of a low-grade inflammatory state that's going on in the gut. That's what we're looking at, and that's what we're working to bring, through the benefit of prebiotics. Now, prebiotics will have an effect on butyrate. We can see all the great beneficial effects of butyrate here. You can pull up this slide again to learn more about it. I'm not going to go into it in detail. What I want to focus on is that, the altered microbial composition leads to an altered metabolite profile and helps to inhibit pathogens that are going on. This is how the prebiotics are having their effect. They're key. So in the arc of my career, I focused first on antimicrobial herbs. I'm not going to use antibiotics. I'm going to use antimicrobial herbs. And then it's more towards probiotics and high doses of lots of different strains of probiotics. And then now moving more into, how do I work with prebiotics to be able to target what I'm trying to do here with my patients? And do I need to will there be benefit of postbiotics to help bring the system back into balance so that it can regulate itself? And do I need probiotics to be able to help with a specific kind of disease state that's been shown to be helpful? So we see that the benefits of prebiotics are myriad here, and they're the fructooligosaccharides, galactooligosaccharides, xylo-oligosaccharides. As I said, acacia root, partially hydrogenated guar gum. There's a number of different agents. Now, there's some things that I've actually moved away from. Some of the like inulins and fructooligosaccharides that are going to be non-specific in their growth potential. So if I'm using a specific prebiotic agent, I'm usually using things more like the galacto-oligosaccharides, xylo-oligosaccharides, acacia root, and PHGG as agents, as well as potato starch. But I have patients focus on, well, what are the probiotic-rich foods that are really, the prebiotic-rich foods that are really going to make a difference overall? And a lot of times that's going to include, those things of modifiable starches and soluble starches. One of the things I didn't mention, modified citrus pectin, that I find to be super useful. The arabinogalactones that I've failed to mention thus far. All of these agents that can be used as specific, or they can be used as a part of the foods that we see over on the right-hand side of the oligosaccharides. The oligosaccharides are going to, help to prevent constipation and diarrhea. They have a very low glycemic index. They're water soluble, and they don't bind minerals. Something like modified citrus pectin can have a tendency to bind minerals. So the oligosaccharides are beautiful in that way. The things that we have mostly available in the United States, guar, PHGG, fructooligosaccharides, xylo-oligosaccharides, arabinogalactans, asamannan. These are great tools to be able to use, and the dosages are talked about here. And so what we find is when we start to look at specific prebiotics, such as, what are the things, as we see here, licorice and slippery elm and triphala, and they have an effect that can increase butyrate. But we also find that licorice and triphala will increase propionate. We don't want as much propionate. We want more butyrate. Propionate as an agent is going to have more central stimulating effects. Acetate is going to have more effects on the biofilm formation, whereas butyrate is going to have more impact on overall metabolism that's going on as we begin to see that. So when we get into the feeding of what's happening here, of the different prebiotics, we want to be able to consider. Just 1 second. Sorry. Where am I here? I think I need to go back one. In looking at the lab assessment, we can see what's happening with butyrate, what's happening with the overall total short-chain fatty acids that are occurring here. We'll move in the future towards understanding, what are the virtual metabolomics that we're measuring? What's the potential to be able to produce butyrate and other short-chain fatty acids? Are you in a good place? Is there a good balance that's going on in terms of the species that are there and the DNA and the enzymatic patterns? And then what's actually being produced? So this is exciting to be, kind of getting more granular to be able to say, how do I bring balance to the overall metabolites that are going on in the gut and in the bloodstream? And that's where, I see the opportunities to go in the future. In the meantime, simple approaches that are going to be food-based approaches of these prebiotic foods that I talked about are going to be key. And these are new things in your patient's diet, so you're going to need to coach them and help them along the way to be able to do that. So we see is, there are many different types of prebiotics that come from, different food items in our diet. So as we see here, we see the bacteria that are present there, if you will, in these little Pac-Man forms, and the food that comes in, and it eats the food, the different kinds of prebiotic food that we're giving it. And then it makes molecules, and those molecules are going to have an effect. When we look at molecules like the short-chain fatty acids, or we look at molecules like the urolithins that will have an effect on mitochondrial function and fatigue. Some of those postbiotics stay present. Some of them, move out of the small intestine into the gut overall itself. So what we find is that when we look at the gut, we find that these molecules, some are absorbed in by the colonocytes to help them to be able to function well, like butyrate. Some of them are neurotransmitters that may go up to the brain. Some of them are cytokines that are formed that have an effect on immune modulation.
paciente que